So, hello everyone. Today we will be discussing about on-field assessment in sports and in sports injury. The key principles on sports injury assessment. Injury evaluation is the first stage of treating the injury. As a sports therapist, make sure that you know what you are working with before you attempt to advise. Treat or rehabilitate your client. When assessing client, you will go through the two processes, the subjective assessment and the objective assessment. We're gonna have a look at the subjective assessment first. The subjective assessment of your client is the history taking stage of the assessment where the client describes their injury. It is always the first stage of any client evaluation and precedes any object testing. However, you must try to get your client to be as clear as possible with the information that you give. This is called the subjective stage because the client is offering you information about the injury, such as how the injury has progressed or regressed since it first occurred, or how much the pain they have been in. You cannot be certain of the accuracy of this information as people might over exaggerate or play down the significances of an injury. Moving on, below are some suggestions for a question to ask when conducting a subjective assessment of your client. Although the questions will be determined by your client's activities. First, how and when did the injury happen? Then, the onset of injury, was it sudden or trauma? Then, what were the surface ground conditions look like? Then, the current sign and symptoms. Do you have any pain, discomfort? If yes, the locality of pain, the type of pain, is it local or referred? Is it constant or intermittent? Then what has happened to pain over last 24 hours? Moving on to the objective assessment. The information about the injury by looking at the injury site, palpitation, observing specific functional movements and completing any specific test. Your aim during this stage of assessment is to determine the degree of functional losses and gains during the injury period. And the management of the athlete who has collapsed begins before the injury occurs with the proper preparation. Depending on the location and level of the event, resources may be limited. At the very least, it is imperative that physician has quick access to a phone and medical kit or supplies, and most importantly, ability to transport the patient to a medical facility. When an athlete collapses, it is important to consider both medical and surgical problems. The list of potential problems is long, ranging from an asthma attack or cardiovascular event to severe head injury, concussion, or skeletal trauma. Here is the primary survey as differentiated at A, B, C, D, E. A stands for airway and cervical spinal control. Make sure the airway is patent. Log roll patient if necessary and apply rigid neck collar. See if there is any neck injury. B stands for breathing. Make sure the patient is breathing spontaneously. C stands for the circulation. Make sure the patient is hemodynamically stable. If unstable, address intravenous replacement and identify sources of blood loss. Here, we check for abdominal musculoskeletal trauma as cause of occult blood loss. D stands for the disability. Assess for neurological injury. Assess for significant musculoskeletal trauma. B assesses for head injury, concussion, Peoples and Glasgow Coma scale, where we see the eye opening, the verbal response, the motor response. We see fractures, dislocation, and neurovascular limb injury. The E stands for the exposure and environment. Make sure patient is in a safe environment with controlled temperature. Check for heart-related illness and cold injury. Moving on to the secondary survey, where we do the head-to-toe examination. We examine the patient from their head to the toe. The ears, eyes, nose, the throat, teeth, gums, the respiratory system, the cardiovascular system, the abdominal and genitourinary examination, the musculoskeletal examination, neurological examination, including cognitive functioning and provocative testing. Here we see musculoskeletal injury. If there is an injury, we usually apply the RICE therapy, which includes rest, ice, compression, and elevation. Splint if necessary, crutches if required, transfer if suspected fracture, ligamentous injury, or neurovascular concern. We observe the potential to return to play, out of play, follow up arranged, transfer to the hospital, or if can athlete play safely, can athlete play effectively, can athlete play pain free, or he can return to play. If not, then we transfer the patient to the hospital or they stop the play. Moving on, the initial assessment always should begin with a primary survey, which is performed on the field before moving to the patient. It is helpful to adopt an ABCDE approach, as we have seen it earlier, the ABCDE approach. Here you can see that. Now, moving further, the ABCDE approach is the airway. A patient airway is a priority. B for the breathing. Effective breathing is essential. The circulation, adequate oxygenation is crucial. The disability, the level of consciousness. Then the environment, sign of concern on around the patient's body. By using the ABCD approach, hemodynamic instability from an axial fracture should be identified readily. In the acute setting, most musculoskeletal trauma may be treated temporarily with modified activity or rest. Ice for the first 72 hours, not heat, compression and elevation, the rise. The injured area may require splinting depending on the severity and the type of injury. Any major injury with possible fractures or ligament disruption should be referred to the hospital for further assessment and for further examination. Moving on to the rise, which is, as you can see, after an acute injury, we tell the patient to rest. We ice that particular area with an ice pack or an ice immersion. We do the compression by craft bandage or brace, and we elevate the limb to reduce the swelling and inflammation. Moving on, it is the responsibility of the sports medicine physician to determine the further management for the fallen athlete. The options include first, sending the patient to the hospital for the treatment or further investigation. What happens? It evaluates or examines the injury so that we can get a proper diagnosis so that we can give the proper management and the physiotherapy management of that. Then taking the player out of the play and arranging follow up. Then observing player on sideline for potential return to play. Then for returning to the athlete to the play. Next up, clearing a player for return to play involves determining whether the athlete can participate in sport safely or can play efficiently. The physician or the physiotherapist apply a few tests so that he can examine the player before his return to play, so that he can evaluate if the athlete is totally fit and be able to play again. The principle of managing injured athlete. Here is some abbreviations such as DRSAC, SABCD. This is the crisis management. STOP is an on-field assessment. Two tabs is a complete assessment. First, we will have a look at the crisis management that abbreviates as DRSABCD. DRSABCD is the danger. D stands for the danger. We ensure the area is safe for yourself, other, and the patient. R is the response. Check for the response. Ask name. Squeeze shoulder. Response. Make comfortable. Monitor response. If no response, then S stands for send for help. Call 000 or dial 100 for an ambulance or ask another person to make the call. A stand for the airway. Open the mouth. If foreign material present, place in a recovery position. Clear airway with finger. Then moving on to B, or that is breathing. Check for breathing. Look, listen, feel. If not normally breathing, start the CPR. C stands for the CPR. CPR 30 chest compression within two breaths. Continue CPR until help arrives or patient recovers. D stands for the defibrillation. Apply defibrillator if available and follow voice prompts. This is the crisis management. This abbreviates as DRSABCD. It requires in an emergency. Then moving on to the principle of managing the injured athlete again the STOP formula. STOP is an on-field assessment done to quickly assess the injury and determine if further assessment is required or if the athlete can continue to play again. Stop means that the athlete is stopped from further practicing, participating, and the game is only stopped if necessary. You then talk to the athlete, determine what happened, how it happened, where it hurts, etc. While talking to the athlete, you observe the area and the athlete. From this pass on-field assessment, the assessor determines if the athlete can continue or if they need to be taken off for further assessment. The play only stops for 1 to 2 minutes to check and evaluate if the injury is severe or not. Then the P stands for preventing further injury, which comes by taking the player off for further assessment if required. Here is the stop formula. S stand for stop the athlete from participating or moving. Stop the game if necessary. T stand for talk to the injured athlete. What happened? How did it happen? What did you feel? Where does it hurt? Does it hurt anywhere else? Can you play on? If no, arrange appropriate transport. O stands for the observation, or we observe whilst talking to the athlete the general condition of the athlete. Is the athlete distressed? Is the athlete lying on an unusual position or posture? The injury site. Is there any swelling, deformity, discoloration? Is there any laceration? Or can the athlete move to the injured part? If yes, does it hurt to move? Is the range of motion restricted or painful compared to normal or other limb? If no, arrange the appropriate transfer. P stand the prevent further injury by ensuring detailed assessment using toe taps. Then moving on to the next step, that is toe taps. If the determined from STOP that further assessment is required, then the two taps protocol talk, observe, touch, active and passive movement skills test is used. Here is the two taps abbreviation. The two tabs is T stands for the talk, history of incident, individual. O stands for the observation, expose and compare for swelling, discoloration, deformity. T stands for the touch, compare to uninjured side, tenderness, temperature, pain. A stands for the active movement. Athlete moves injured part through full range of motion only to point of pain. P stands for the passive movement. Sports trainer move injured part through full range of movement only to point of pain. S stands for the skill test. Athlete perform progress skill test appropriate for the sports. Moving on, this is it. We will be continuing the off-field assessment as well in the further slides. Thank you guys.